I see.
Yeah.
But still, this is good, right?
Yeah, it tells us that we are able to capture most of the cases, but we
Yeah.
don't know if we missed, if there are lots of false negatives.
Hmm.
Yeah, let me text one more message.
Mm.
I don't have Byron's phone number. Oh, I do have
Oh, I think how come I remember seeing his email said that he will be in the hospital all day
today.
today. Yeah, was that his email last night?
Oh, I did not read it carefully.
Yeah, he said I'll be in the hospital all day
Okay, so he will
today.
be able to join.
I guess, but
Yeah. Oh, I do have Byron's.
okay.
Okay, that's fine. I haven't got a reply back from Lawrence, so I think what we wanted to, Kristen, the RFA has not come out yet, but keep a close eye on the announcement, the website, because they said it's coming out anytime soon. Those were approved. I think the announcement was approved. It's just it's getting in line to get published.
Okay.
Not sure when it will come out, but it's soon.
Okay. Is that still correlated with the UO1 whenever you and she and I were talking about it and we were on the website?
The website,
The NIH website.
yeah, the NIH website, and where they announce the new funding opportunities.
Okay.
Yeah.
I even asked May. I was going to share just to be sure because I was like, she said it should be coming out soon, and I want to make sure because he had said type in UO1 here, and so I always make sure it's the latest release.
Also maybe sometimes not using UO1, maybe type in like SysNet or like
Okay.
whatever that is the short what SysNet stands for, or like simulation modeling.
Okay.
Yeah. Modeling would be a lot. Yeah, simulation. Simulation. Yeah. This narrowed down to but anyway, simulation or simulation modeling.
Okay.
Yeah.
I will use those keywords. Okay. I just want to make sure that I am keeping on top of that and I know exactly what
Oh,
I'm
Lawrence.
looking for so that I can make sure I can tell you.
Hi, Lawrence.
Hi, Lawrence.
Can you hear us?
Hey, sorry. I just saw your text and logged on. I've been in the process of moving, and then there's like some other stuff with one of my per diem jobs. So yeah, but I can attend the rest of the meeting. Yeah.
Okay, good, good, good. So how was the conversation with Marty the other day?
Oh yeah. So it was good. I think
Good.
in terms of the overall um the overall message he had, I think, was the idea that for starting the study, it would be good to model it like a clinical trial where you have really defined inclusion criteria and exclusion criteria, almost like a target trial emulation approach, even for something like this that's more longitudinal. That way, like it really captures the true population, and then, and it basically like his point was that this was the really short median time like reflects that maybe the inclusion criteria wasn't rigorous enough to show the actual population of interest, since likely a lot of people had diagnosis at the time that the SPEP was sent out. So he recommended that, but then I also explained that like for our purposes with to get an idea of the early data, like we don't have that methodology to be able, because that would require that the NLP can capture every lab test, every diagnostic test. And so right now we're using like the surrogate method. And so at that time we had talked about if we apply the exclusion and the median follow-up time looks more appropriate, then can we at least present the data? And then he was okay with that. So that was kind of like the follow-up to that discussion.
I see. So are we turning this into a manuscript, or there is no way with the current data?
So to be honest, like because I looked at even the update that Qingyun sent, even I didn't get a chance to update it into the ASH abstract just because by that time it was kind of too late, But even looking at that is challenging because when we had the high percentages of progression, higher than the historical data, it was with a very low median time to progression, right? But then then the opposite is true where when we applied the broader exclusion, then like there's a longer median time to progression, but then the event is so much lower, like it dropped by more than half. So now it's like the progression events is lower than the published data.
Hmm.
Yeah.
Yeah, Marty just joined. Yeah.
Hi, Marty.
Hey,
Hey, how are you?
good. Yeah, I mean, I just to sort of echo on what you were saying. So, the difference is that the other ones were in a sort of registry or had a clinician review every single thing. And as we were talking about, you can get an MGUS that's positive, that for IgM, and then it takes you a while to make a diagnosis of Waldenstrom's. It doesn't happen like the same day. A lot of times it's also an indolent type thing. And so it just, you're not in a rush. So then you get a lymph node biopsy and then you get whatever things. And so those are not really progression. They're just, time to diagnosis. And so that's the difference, is that we have to understand how you got into the Mayo registry is very different than how these patients were selected. And that's why I had some problems with saying, that, oh my God, these things are comparable, because I feel like they were not comparable because the methods were so different.
Yeah, we cannot make head-to-head comparison, but is there any way that a retrospective study like ours can help identify some sort of signals in the cohort, IgM cohort, and do something about it, not making head-to-head comparison, but with a better defined outcome and stuff like that? Would that be something like a project in the future, or we should end it here?
Well, I mean, the original background that was written related to the differences between white and black. But then the conclusion was not that at all. And so, if you have, if the, because the gap is that the Mayo group is all a bunch of white people, and that we have at least, some black. And so it is completely appropriate to do a comparison between white and black in the VA to say, well, what is the age of onset? What is the rate? Because you're using similar methods in both groups. So I still think that is a reasonable thing to do. I just feel like unless we were to dive a lot deeper, I don't know about comparing to someplace else. And then also, I just don't know where this is going. Like, what is the problem that we're trying to solve that we think retrospective data is going to solve? Like, is a brand new model going to like change care drastically. And so I just sort of started to think about like, if I was going to write a grant, like what is the grant that I would want to write to get funded? And like what is the, impact that like someone is going to give me $1 million to do this?
Well, I think Lawrence has tried to put the IgM progression into the context of the progression of MGUS to myeloma similarly. So trying to identify some risk factors that can be possibly potentially modified. So I mean, not we, I mean, we think that if IgM progression is also there is a chance to prevent this progression, that could be something that would be interesting to look at that can be fundable. But I'm not that familiar with IgM progression, and I don't know enough to say that this is definitely not possible or it is really possible. And so I wonder what your thoughts on this.
Well, I feel like we have so much work in myeloma that we have so much work in myeloma that we could potentially do, and that yes, we could replicate a lot of it in Waldenstrom's and IgM progression. I just, you know, I you've got to figure out what juice is worth the squeeze. And Lawrence, that's what I was sort of telling you, like where do you if this is where you want to be, and then we need to write up a plan and figure out like where do I want to be in 5 and where do I want to be in 10 years. This is a smaller cohort than we have for other cohorts that also there's not as much, there's just a different set of morbidities and things like that. And so like I just, you got to think about like, where do you want to play in what space for your career?
Yeah, I think basically kind of so going back to the original purpose, it was because this is even just IgM MGUS alone, it's already such a rare precursor state, like incredibly rare. Because again, the Mayo studies, they all only had at any time 200-ish patients for the IgM alone. And so we already have a very big population. So I did want to study like risk factors for IgM MGUS progression, since it does progress at a higher rate than the standard MGUS. And the disorders that it can progress into are like it has a higher chance to progress into more. I mean, yeah, it has the indolent lymphomas are definitely always like a progression event, but it also has a chance of it progressing to other more not as indolent disorders. And then so that's kind of the big purpose, and we have such a big data set to do that. We already have a lot of methodology that can do that. It would just be more capturing like the things that we would need to develop would be capturing the progression events. And then I think that's kind of also the challenge is then looking into the literature of the like of that has already been done by the Mayo group and also even by other groups. Like there's not a consensus. I think the challenge was that there's not like as in myeloma, there's really not a consensus for how these disorders are characterized. So even like the Mayo group pretty much advocates a very similar criteria for progression to myeloma, where you need 10% LPL. But there's also another organization. I forgot what the formal name is, but they've published a few times, and they actually just say if you have any LPL cells and like some other clinical event, you can call it Waldenstrom. And then there's also like this whole thing, is it asymptomatic Waldenstrom's or slash smoldering Waldenstrom?
Yeah.
And with the Mayo studies, like actually I read it extensively. I know they had a registry and they talked about having clinicians review, but they don't necessarily state like, was it Waldenstrom that needed treatment or like what was the criteria? That's actually not, I mean, to my knowledge, I've read the studies, both studies like so many times. They actually don't even delineate that really well. So I think then from there, so that's kind of the challenge that I had when we were going through this preliminary data. I mean, I think one thing you brought up a really good point, which is like, the idea, is it disease reclassification or is it true progression, right? And I think maybe one thing we can do, because I think like this is all apples to orange comparisons, which I thought that point was like that actually was a point that really made me reflect that maybe at this point, it's like you were saying, the progression event shouldn't be to the asymptomatic state. It should be to like clinically, like require like Waldenstrom that requires treatment and or lymphoma that requires treatment. Because then it's not like we can basically say these are different comparisons, these are different studies. And this is our strict criteria for progression, because it's the most clinically meaningful as opposed to disease reclassification. So I think maybe that would be the better focus to make this more measurable, and the data to make more sense. And also it would avoid getting directly compared to the Mayo study, because then the Mayo study doesn't actually say like, was it people that required treatment or was it like Waldenstrom that required treatment or not? So at least we have something that's very well defined, and we know that our NLP works for it.
Okay, so you're saying that our outcome, I agree, I guess the outcome should be treatment then. So I mean, I guess, so like, I just want to like, so are you writing a proposal to like, or like a summary of like a protocol, like what you want for this? Because, in my mind, what we need to do is we need to have like a written out proposal or protocol to sort of think about what is the data that we all need, that what you need, what is the analysis that then needs to be done on said data, what is it going to be, what's the product in the sense, and then where is it going to be published and what funding are you going to get or going to get, like, or is this like preparatory to funding? Because sort of thinking about your, career and, everybody's like work and things like that, we have to think about, what would be like if I was to apply to the ICTS or I was going to apply to leukemia lymphoma, like where are we going with this? And so I think that's a totally reasonable strategy, but I do think we need to have like a roadmap so that that we have like, okay, where are we in this and what can we expect, so that we know like, yeah, what we're doing. And that, I mean, for you, when you think about like developing your career, like I want you to be able to, advance and then like have something for it. So we need to say like, what is your 1 year target? What is your 5 year target? Like, how can we support that? But like, it means that like, each project has to have like sort of a deliverable and, what are the things? And so that therefore we can support you to achieve, where you want to go.
Yeah, I mean, I applied like a few months ago. I sent in a submission to a grant proposal to the Waldenstrom Foundation,
Hmm?
and they couldn't give feedback, but they did say that like it scored pretty well, but then there's just like a few other proposals that were granted higher priority. But yeah, it would be something like along the Waldenstrom or lymphoma sort of foundations. I've looked into like all the different foundations that you mentioned. I think those would be they all have a similar funding mechanism. I think the one I'm looking at is like the Career Development Award, where it provides like maybe like 2 to 3 years and like 50 to 70K per year. I think that would be a good one for this project. And then career development wise, I mean, largely I want to see myeloma patients in Waldenstrom, but honestly, like the Waldenstrom is just so rare that even from a clinical perspective, it would be really hard to like run trials like outside of like a cooperative group. So yeah, I would be both doing like myeloma early phase research and also if I have the opportunity working on Waldenstrom cooperative group trials, but then also publishing um, studies in prevention. I just don't think like it's possible with the low volume to do formal IgM MGUS prevention studies.
Yeah.
Like,
No, totally.
but
And I'm
yeah.
so glad that we're talking about this now so that we understand the goal of this, that the goal of this is not that we're actually going to translate this into a prospective clinical trial. The goal is that we are going to create a risk score and then we're done. And that's what I'm trying to figure out is like, where are we going so that we can put the pieces, the building blocks, like what kind of foundation do we need so we can go somewhere?
Yeah, I think it would be largely like a population, like a population-based studies and like yeah, risk scores, these sort of things using like a database as opposed to yeah, I just don't think it's possible to move forward to actual prospective trials with such a low amount of,
Great. And so, yeah, so that would be my suggestion. Like I'm not really in charge of this group, but like in my prostate group, I ask my people who I work with who want to, use the database that I've developed and the analyst time that I've, and all that kind of stuff is like, all right, where are we going? Like, let's write it down, and so that we know where we're, how I can help. Because also I get lost, because I get lost, and so I just want to know. And so I would think about this for this project, so that also for like, the submission like we had talked about 2 weeks ago, where, like just so that we all know what we're doing ahead of time, and that we don't get surprised by analysis and expectations.
Yeah, gotcha. I mean, definitely I can draft a protocol for this because I already have like a proposal I had drafted, and it has some aspects of the inclusion criteria. I can expand more on that, like in a formal protocol.
Fantastic.
Yeah, but I think that if we are looking at the next steps, what can we do to provide some sort of preliminary data for your next grant? And that's important, right? So if you can narrow, because I remember in the abstract, you look at a lot of outcomes. Outcomes also defined by a lot of different criteria. I think maybe we can narrow down to Waldenstrom with treatment. Would that be something that's more targeted and more focused as the next step for this project to produce some sort of deliverable instead of just letting it sit there and then just developing ideas and not going anywhere? What do you think, Lawrence?
Yeah, I like that idea to focus just on Waldenstrom. Yeah, because I think then it would be a little bit more focused. It would be easier. There's not all these criteria to progression, and then in particular, like looking specifically at like what's it called? Like clinical progression, meaning requiring treatment, as opposed to the asymptomatic states, because I think that just at least we have something we can delineate, make it very clear and understandable.
Yeah, I mean, I think that, we have a sort of paradigm that we have for myeloma, that we consider people that have an MGUS and myeloma within like 6 months, we consider them to have, myeloma up front. So I would be interested just to know how many people have Waldenstrom up front and get treatment within 6 months, which is, similar to myeloma, and then how many people are diagnosed and then don't get treated for more than 6 months or never get treated. And so that is, I think, a wonderful paper to think about. And then you can look at what are the features that are, associated with treatment, and complication, but like that sort of framework that, has already been developed, that we can apply that same framework to sort of, understand, what is the landscape, what are the numbers, how many people are immediately treated, how many people have delayed treatment, and how many people are never treated. I think that would be, I think a good thing to do. And then, that data should be able to, move whatever, project you end up wanting to apply for funding for.
Like, sorry, comparing the IgM MGUS that requires treatment to the ones that don't.
It's not, well, I mean, it's really more of a descriptive in the sense that, but yeah, I mean, you could say that like what, like, so I mean, I'm sort of like discussing an overall framework from which
not
you
really
can
comparing. It's just they could receive treatment. Sometimes they don't receive treatment. We could also try to understand why they don't receive treatment, but right now it's just the structure that how IgM MGUS progress, and then the outcome would be Waldenstrom and some with treatment. But we can focus on Waldenstrom with treatment to do any analysis. But in the structure, when we describe IgM progression, we can focus on Waldenstrom with treatment and without treatment, and also maybe in the future find out if they don't receive treatment, what happened to them.
I
should
see.
say what I'm describing is a structure, or another word for it is cohort creation. We need to create specific cohorts in which we can analyze analytic questions. An example of a cohort is someone who is diagnosed and treated right away. Like that is a certain set of patients. Another cohort is a patients who are diagnosed, but they don't treat it or they have treatment down the road. They quote progress. And another cohort is people who never progress at all. And that like in at least, in retrospective research, cohort creation is like the most important. Thinking about like who's in what cohort, how did you get there? Why is this? And this is why I think you had, quote, a lot of progression is because we didn't really think about your cohort and then what your outcomes were because we didn't sort of strictly define like, well, what are we defining as progression? All these sorts of things like, and so in my mind, going from a IgM to a ICD code of Waldenstrom's is not progression. Like that is, you just got a new ICD code, or as you said, reclassification. Progression is getting some treatment or whatnot, developing a problem of Waldenstrom's, losing your eyesight, having hyperviscosity. Like those are progression events. And so that's why I'm saying that we need to go back to create the cohort. And then in each cohort, think about what is our endpoints. And when we decide our endpoints, then we can look at the factors that are associated with your endpoint. And so you think about, again, cohort, endpoint, and covariate. And so each one of those things we have to sort of structure so that we can actually do worthwhile analyses.
I see. Yeah, I think that really clean up the study.
Yeah, so when you start to write the protocol, then we can help prepare the analyses. Right now, Qingyuan has already pulled together the IgM cohort, and you need to give him a clear definition of the outcome, and so can help you get those data out. And then whatever analyses that follow the clean definition of cohort and clean definition of outcome, we might not know the exposure for now, but we can do some sort of analysis and find out any factors that actually contribute to the progression. And then maybe we can define some exposure and then look more into the exposure in the future. But that's the first step is to have clean cohort, clean outcome, to be able to think about the next steps.
I see. Yeah, makes sense. Yeah, I'm just in my mind kind of brainstorming like how we would define progression. I think if we're focusing on Waldenstrom, at least for right now, where the NLP algorithm is at, I think we would still have to be using ICD codes, but we at least have that list of treatment and CPD codes that we can say, ICD code plus receipt of this treatment.
Yeah. And maybe we need to have some chart review to get the outcome out and make sure that we have a clear definition of the Waldenstrom, not just rely on the code.
And that's what these types of meetings are for, in the sense that we need to discuss these. Like, what is the endpoint? What is the question you're asking? How do we get, I mean, that's what, I feel like half the time when I'm on with Kristen or Ken Carson or Sushin or whatever, we're discussing these like key things about how we define our endpoint and whatnot. I mean, I feel like with our merit award, Sushin, that we tried to write with medicines that didn't work, we spent so many times like, what is our endpoint? What is like, like these types of things are just like, unfortunately, that's the nitty gritty of science that we, have to, to focus on. And that, I always like endpoints that are similar to clinical trials, or that someone who is a clinical person would understand, like you don't know me that well, but like with my fellows, I'm always talking about endpoints. It's like, oh, was the endpoint of this trial overall survival? Oh, was this endpoint progression-free survival? Oh, was this symptomatic? Like, what are the endpoints here that we're talking about? And so therefore we can discuss, why does, when people say, oh my God, acalabrutinib is so much better than blank by blank, and be like, well, that's a PFS endpoint. Didn't improve overall survival. And you had to spend $100,000, or whatever it was. Like, that's fine. Anyway, I won't drone on. But this discussion that we're having right now, and all the future discussions about all these things are incredibly important for long-term success and valid science.
Right.
Yeah, yeah, I agree. Yeah. And then hopefully we can develop more of the NLP to be able to capture all these. Because I think in it long or not long term, but like, in the next few years, it would be nice if the NLP could potentially capture like more of the lymphoma endpoints, meaning like being able to incorporate a lot of different diagnostic studies. And it would only help for the myeloma side as well.
Like what?
Like being able to characterize because I like on the myeloma side, we're already working on trying to capture lytic lesion or even just bone myeloma bone lesions. But in the future, like if in the
You
process
have a
of
world expert
Mm,
in this call right now who is capturing myeloma bone lesions.
mhm.
Yes. Trying very hard.
I know. I'm saying
Yeah,
we're working on it.
yeah, but yeah, we're actively working on that, and then it really elevates the NLP if we can capture like because on the lymphoma side we have more of the lymph nodes and we tend to see like you know more of the like extramedullary type lesions and so it would help on the myeloma side as well for the patients that have that kind of progression because at least a third of patients will experience it in their myeloma disease course, so I think
But
yeah
I
overall.
would push back a little bit. How many
Mhm.
people progress and then don't get any therapy and then don't die?
um It depends on which type of progression. So like biochemical progression, it is a lot, where if it's just purely biochemical, the whatever lab marker is rising, there a lot of myeloma doctors may not even treat them until they
Oh, I
develop a
agree.
sign of a clinical progression. Yeah. But
Exactly
there
right.
are there are still patients that will develop the more catastrophic, like they can represent with any of the crab features, or even like we see more these days where a lot of patients will develop the extramedullary disease.
Totally.
And then
But
it's like,
or it's I treat all of the hematologic malignancies here in this VA.
mm,
I don't know if you know that, but like I do all the lymphoma, I do all the
yeah.
myeloma, I do all the CML, AML right here. So I'm saying I know exactly what you're saying, but I'm saying that we actually the imaging endpoints are not that great. As you said, we have a lot, like treatment should really be our endpoints, especially
Mhm.
in retrospective data, because there's a lot of heterogeneity, and that even in clinical trials, like what is the progression events, what is PFS? PFS could be a rise in those things, but and RECIST. And so I would love to be able to develop a RECIST type criteria that we have. And I'm collaborating with a Merit and with UCLA that's collecting every imaging. So we're hopefully going to do imaging AI. But like I would argue that it's going to be really hard in retrospective data for that for a while, and that in the meantime, we really should use treatment or biochemical as our outcomes, and because I'm pretty sure that that's going to be the best we have. So like thinking about let's not like say we can't do something and have the perfect be the enemy of the good. We have many good endpoints. And let's be creative about our endpoints, and let's not say, oh, because I don't have imaging, I can't figure it out. Well, what are you talking about? If you start somebody on a relapse myeloma treatment, they probably relapsed. Now, maybe I would argue a lot of times people like get scared, as you said, and like, the M spike rises and they freak out, and all of a sudden they're giving them like, all this crazy stuff. I'm like, so what? Their M spike was 0.6. Who cares? But like other people, get freaked out about it. And so you could argue about that. But otherwise, I think that we have wonderful endpoints. We just have to discuss them. And I think we have a lot of good things. And we don't have to wait for for May to be the perfect LLM creator that she is. But we can do a lot right now.
Yeah, that's true. I know a lot of the retrospective, like the large databases. I know CIBMTR does this a lot where you use like time to next treatment,
Yes,
which I
exactly.
think, yeah, I think it is a good surrogate, like for PFS. And I mean, overall survival obviously is
Yes.
pretty easy to use. But I think like from the standpoint of being able to develop like inclusion criteria, it is nice to potentially be able to have the algorithm like read PET scans as well. Like from in terms of excluding other cancers and the some of the like developing like the actual cohort for the retrospective study. I think especially on the like lymphoma side and Waldenstrom, I think it would be nice to have that.
Totally agree. I'm waiting with bated breath for our LLMs to be developed.
Yeah.
As I said, I even want to put some money towards it. And so that's why we got to talk about not maybe not this call, but like I want to, throw some cash and or if I can get it so we can develop this in multiple because I hope from what you guys have talked about, like we can develop it for one disease, we probably can apply it for many. And so I hope. And so I think I'm excited.
Yeah,
Yeah. I mean, I think it's really exciting. Yeah.
yeah. Hopefully we have sustainable funding for doing more work.
Right, that's what I'm saying. That's what we got to focus on. Unfortunately, when times are lean, there's no mission without the margin. I
Right.
learned that from Barnes Jewish. That oh, we don't care about those Medicaid patients. Screw them. There's no mission without the margin. So let's work on our profit margin here, and let's we might have to sell out to some pharma for a while, but we got to keep the engine going.
Yes, yes, exactly.
Yeah. Alternative sources of funding. But yeah, I think like once I want to hit the ground running with like just applying for more of the lymphoma grants. So I need to kind of go through. I at one point compiled like a list of all the different RFPs for these like early career sort of awards. And so yeah, I think I already have the proposal. I think if I refocus it into just looking at Waldenstrom and then I think maybe in that proposal, the outcomes maybe weren't as clear. So I think if I clarified that, then it'll be very helpful. And then, yeah, like I think for now we're looking at progression to Waldenstrom, but in the future we can also potentially look into like time to next treatment and overall survival. But at least for the early phase, I think uh, I can try to write like a clear protocol and also re-edit the proposal to be more focused.
Yeah, that's important.
Yeah, but this is very helpful though, because I think, I think especially looking into like this rarer disease space is more challenging to really write a good study.
Yeah, so another project that Byron and Lawrence are currently leading, the trend of myeloma diagnosis, not the trend of myeloma diagnosis by itself, it's the low burden versus high burden myeloma trend diagnosis. And especially after the slim crab criteria, the burden, I think within this meeting, we have discussion about how we define the low burden versus high burden. I wanted to revisit that criteria because I feel like we don't see that the low burden is actually increasing after the slim crab criteria after 2015. But then I think the high burden also increased as well. So I don't see the clear difference between the two. So I think can we revisit the definition of high burden versus low burden? And the definition, I think they, Marty, I think you were included in the abstract that Byron sent out, right? So he has the definition of high burden versus low burden. I think it's that I want to run it by you to see whether that is reasonable.
Yeah, I mean, I would just have to review, like, in any biomarker, you have to think about, developing it and like, is it able to distinguish something, and that I would have to look at it, and I'm not really sure. What was the main features of low versus high, or I can look at it because I don't
Do you have it in front of you? The burden, the high burden versus low burden.
Sorry, yeah, I don't remember off the top of my head either. I think this will be a good refresher. So I think we talked about it like at least for me, the last conversation was like several meetings ago, and then I think it was like an or statement, like a list of different things in an or statement. That's what I last remember.
Is this the XGBoost one?
Say again, which one?
It had like XGBoost and potassium and sodium and all those sorts of things in there.
No, Qingyuan is not that one, right? different one.
Is this it?
I
No,
don't
not
think it's
this one.
this one.
No,
No.
not this one. High burden versus low burden, ITS analysis.
All right,
I
I don't
think
think
it's labeled ITS. Yeah, that's what I
Yeah.
remember. It was labeled ITS.
Do you have the definition of the high burden versus low burden?
I don't know that I see that, or that I don't remember reading it, but maybe that's also my lack of paying attention. And how well did that perform? Or again, sorry, what was the endpoint that we were trying to validate this?
The endpoint is we are trying to see the trend of patients who were diagnosed with myeloma
Ah,
at
okay.
low burden. And then we hypothesize that the number or percentage of low burden will jump up after the sling prep criteria.
But haven't we already been like, I guess I would look back is that we haven't even been able to prove that like, I mean, we've been working on proving that there's more slim, and we haven't even been able to do that.
Well, yeah, that's in a different context.
Right.
Amendment was working on it, but here this one is slightly different. This one is looking at we are expecting that they were diagnosed at a earlier stage, meaning that low burden. That
Right.
was through discussion.
But that's the same thing, is that slim is the equivalent in my mind of low burden. Like that, yeah. So like, and that we like, and slim is what is used to actually diagnose, and we have not been able to prove that there's more slim. And so I'm not sure that we would be able to prove, these are all surrogates. And so I think that we're going to struggle with this until we can figure out how to prove that there's more slim. And that, because our hypothesis is that you're right. I'd be totally my hypothesis that there'd be an increasing amount of low burden over time and a decreasing amount of high burden. But our hypothesis also was there'd be more slim and less crab, and we haven't been able to prove that yet. Or at least I would say that we're slowly working towards it.
Yes. So I think this is from kind of similar, but from a different definition of high versus low burden. Not sure whether that is worthwhile digging into.
Yeah, I mean, the other thing is like, we're basically, it looks like we're using the RISS criteria plus
Yeah.
plasma cell percentage. Like that's, I mean, those criteria I mean, anyway, yeah. Like, I
You don't like that criteria?
well, it's not that I don't like, I mean, just like, I feel like we're getting the cart before the horse, that like, we have so much, like, I still want to know, like, we haven't, I mean, this is maybe selfish of me, but like, what has been the use of the drugs over time? Like, what are these other sorts of things? And like, what is our like, I feel like the slim crab stuff is like I feel like this is going to be harder to do, and that the yield, like this, making a new definition, because like I've never heard of this before. Is this published somewhere?
No. It's just through discussion. I think I don't know.
I mean,
I don't remember
so
what.
yeah, I can explain it a little bit. So the thing is, in a lot of like registry studies for, so I'm thinking of like CIBMTR, and then not just them, but also what's that other group? The myeloma CAR T group that does a lot of these sort of studies. They tend to have a broad like 4 criteria list of different things that signify disease burden, and then like it'll be like LDH, it'll be bone marrow plasma cells over 50%. And then it will be components of RASS, and beta 2 microglobulin isn't always checked, but sometimes they will use that as well since it's part of the RASS.
Okay, so
So-
this is a published and validated criteria.
It's not published and validated, but it is one that a lot of people these days do use in their studies.
No, but see, Lawrence, this is the difference. Is that like, are we going to use an unpublished, unvalidated criteria that a bunch of experts use to do this? Like, is this going to get us funding? Is this going to advance the thing? That's what I'm just trying to say. Is that it makes me nervous. Like, if we are like doing, you know, yeah, I mean, like this, like biomarker creation is is tough.
Yeah, I hear you. And then I know like in a lot of these studies, like they're also very careful to not call it biomarker just because
I know.
they're also wary of that same challenge. But yeah, because when I think at the time, because I vaguely remember like when I was thinking about it at that time, and I suggested making the list with the OR criteria. Um, I'm trying to remember there was a reason that we were talking about for why not to use RSS, and I think it had to do with the fact that even though it's included on clinical trials, and it's still something that we report on these days, it's not as like um it doesn't have as much of a prognostic implication on patients these days because now we have newer therapies and
Right.
less cytotoxic. So it just I think in my mind it was more just the standpoint that now it may not be as biologically relevant. And then because other studies are now breaking up all these criteria, so instead of like this plus this, a lot of studies are saying this, or this are signs of high disease burden. So I
Yeah.
think those were like the reasons why I was like, okay, maybe we should
Oh, I
just
gotcha.
do this. Yeah.
I just again like because we can do it doesn't mean that we should. And like this, I'm sorry that like I'm sorry. I feel like I'm being an asshole today.
No,
And-
no, no.
No, this is very helpful. I think we need to
Like-
hear this.
Yeah, I
But-
wanted to make sure that the foundation of the study is solid. So that's why I wanted to run it by you because we don't see like the signal is not quite right. And so I mean we see a little bit, but then it's not so that's why I was like we need to revisit the criteria of high burden versus low burden.
Yeah. Okay, the other thing I'm trying to remember is because I remember early on I did suggest maybe we should use like ISS and well not RISS, but I think I suggested ISS because that one's because the cytogenetics I don't think we'd be able to grab right now. And I just don't remember, did we ever actually run that and have the results?
You mean which one? RISS?
Based on ISS. Because I remember when we first talked about it, I said that there's ISS criteria and it was more prognostically meaningful at like early on when it was developed, just because it burden was more like the disease burden was more like tied to prognosis. And so I don't remember if we actually ran that data of the ISS.
I don't remember that. Qingyuan, did you remember that? I think we were discussing this and then you guys were suggesting some sort of criteria and then you emailed, I think Qingyuan was asking you to clarify more specific criteria and then you guys email back and forth about the definition of high versus low burden. But then I was like, is it low burden if one of these criteria is violated or at least two of them are violated? So I don't think if one of them is violated, then it can be so I just feel like the definition of high versus low burden is not that clear and not that I don't know. I just feel like I'm not sure about that. So I think Marty would be the best person to tell us this is not going to work.
I mean, even if you got it to work, the amount of, let's say you develop this criteria. No, nobody's going to use this. Like nobody, I mean, just to be honest, like this, we now have MRD, we now have responsive therapy, we have genetics, something like that. Nobody's going to use this. Like, we've had these features for forever, and nobody else has developed it. And now the field has moved on to a whole bunch of other things. Like RASS is like nobody cares. It's like it's worthless. It's only like where's your MRD, that kind of stuff. And so I worry that like we would be creating something that is maybe would have been good 20 years ago, but is just not of any interest to the field, and nobody's ever going to fund this. And also it's just going to be in some low whatever, it's going to be an abstract, and it's probably never going to go further.
So if we want to define high versus low burden, is there a way to do it?
I guess I think we should be looking at the outcomes of, so let's take a step back. We do not have a good understanding of people who have just bone lesions, who are diagnosed with, or just with anemia, or just with renal failure, or just with hypercalcemia, or just with slim, or just like each one of those categories. I would start there instead of like in each one of those that are a validated reason to start treatment. And then of course you could have 2, you could have 3. Like I would like to know, what is the time to progression? What is the time to like death? Like how many people are dying on treatment, or maybe like there's a lot of other things. What is your response to therapy? I feel like those are much more clinically meaningful and useful prognostic factors because I personally think that myeloma that kills off your kidneys, that is a light chain myeloma, is very different from myeloma that causes a bunch of bone lesions. And I don't feel like I have a good paper that is able to separate those two differences. And we probably can do that. And we can account for the different therapies and a bunch of different things. And therefore, then we're not even creating a new system. We are using the system we already have. Like, I mean, Lawrence, do you know that? Like, what is the outcome of someone who has anemia, who's diagnosed with based off of anemia versus diagnosed based off of bone lesions?
I mean, so I know mostly I read mostly the renal literature. I know the renal is like one of the like worst prognosis if they're diagnosed with that. I think
But I mean, is there a paper that you highlight or that you are aware of that shows like in the modern era, like what these things are?
Like in terms of prognosis, depending on how you present, do you mean that?
Yeah.
I think so. Yeah, that's a good point, because anemia and bone lesions, I don't want to misquote. I feel like I may have read something that suggested anemia, but definitely renal, like you're saying, renal is definitely one where people have actually looked retrospectively and said like this is really the bad one, especially if there's a delay. Like, because this actually, that's a very good point, because I guess the renal side, we're like clinically we're gonna be very, very like cognizant of the damaging issue just with obviously dialysis, but they've actually characterized like the time frame to treatment, how quick of a response you get, and how well a patient does. Like typically you need to get the light chains down by like 90% within a month, or else they're going to have permanent creatinine or permanent CKD.
Exactly.
Yeah.
We have the best data set to define all of that, and even to say the response to treatment. How quickly did they get the light chains down? What was that associated? I feel like I would do something much more simple that I actually think people would understand and would be much more high impact. I just feel like creating a new score is going to take us forever, and it's like nobody's going to pay attention, versus using the existing things that people already use and understanding those effectment on I think would be simpler and also more impactful.
I see.
So
yeah, I think that would be interesting. Yeah.
is there a utility to look at all of the symptoms that indicate myeloma and then have myeloma diagnosis, and which one is more deadly and that leads to all-cause mortality?
Right. And numbers of treatments, all those types of things that I think that myeloma is actually very heterogeneous. I mean, most diseases are. And I think that we have the ability to quantify that heterogeneity. And this could be a series of different things to say who has, it's the same idea with slim crab, but I think people that are slim have a better prognosis than people that are crab. But even if we really wanted to grade that, we could look between crab, the C versus the R versus the A versus the B. We could do all of that sort of stuff. I just think that would be simpler and also just more impactful. And then I still think we can do the, S versus the LI versus the M. I think we need to do that. I just think that like this is work that I feel like would be fantastic. And plus we could potentially actually get all the genetics, which would, or, that would be hard, but we could, we have a lot of new testing that we could probably extract. I would love to get that. Nobody else has that amount of data. And that we would, and that like that, I feel like using the existing criteria and showing the heterogeneity, and then the differences in treatment or even the response to treatment. Because maybe like some treatments do much better because you're going to have people that have only renal, and then you're going to have a variety of different treatments, and you can see which one tends to do better. I would love that. I feel like that's great. We could have like a select your choose your own adventure. Anyway, I got to go to my prostate meeting, and I
Okay.
hope that this is like, I hope I wasn't, again, not too much of an asshole, not too much of different, but just like think about like what is it that we can do we have so much data, and that's the problem is we have so much data, and so like there's like an infinite amount of things we can do, but we have to think about what is going to be useful, and also I hate to say it, what can we get paid for?
Yeah, 100% agree. And thank you so much. I think this is very helpful to like bounce this idea and really like especially with the IgM study to really clean it up.
Gotcha. All right, peace.
Thank you, Marty.
All right, see ya. Thank you.
Okay, I think we have a plan. That's the reason why I wanted Marty to join this meeting to kind of help us define the next step and stuff, because we really wanted to have some clinicians. I mean, Lawrence is also a clinician, but maybe more like senior clinicians
Yeah.
to give us some suggestion because they see more patients.
Mhm.
Have more experience, and also because I'm not on the clinician track, so I don't know what the expectation for your career path. What I can do is to help you answer the research question that you wanted to answer. But I cannot tell you, like, if you want to look at myeloma, then I think I can provide you enough, not in terms of clinical standpoint, but in terms of the research standpoint. But beyond myeloma, like the Waldenstrom or other blood cancers, I don't have the expertise. So I wanted him, who see a lot of blood cancer patients, to be able to provide the feedback and be more critical like the outside reviewers, so then we can be more prepared and be more rigorous about our study design.
Yeah, no, 100% agree. I think it's very helpful, and yeah.
And this is how I was trained without any clinical background. And we have tough internal reviewers or co-authors that help us to make our study very rigorous.
Yeah. But yeah, I prefer that. I mean, honestly, I feel like that feels way better than than dealing with the rejection without external peer review.
Yeah, but at least so far our studies that went out was under the very rigorous this study design, and also rigorous review from our internal reviewers, internal co-authors. So I think that's why every time it took such a long time to have a paper out, not like fast food that you can quickly generate something and then get it out. It's not that easy.
Yeah.
Yeah, that's why I told you that we need to, as the first author, you need to make every co-author happy, meaning that we have to go through very rigorous internal review, and then we have better quality of work.
Yeah. Yeah. Yeah, and then so you saw I sent you the PDF of for the glycemic or diabetic control paper. So I sent it to Annals of Internal Medicine, and it turns out Diabetes Care is actually one of their subsidiary.
Oh,
So they haven't, yeah, it's convenient. So they have an option where if they reject it, they'll forward it to diabetes care.
okay, good. Well, I did not know that, but that's good.
Yeah, yeah, because I saw it as I was submitting, and then I was like, oh, okay. So it gave it as an option. So I think that'll be convenient.
Good, good, good. And diabetes care is already on our list, so it's not distracting from our submission at all.
Yeah, at least it'll be convenient and then have a streamlined process. And then because that one I checked you as corresponding authors, so I think any notification they're gonna send it to you directly.
Okay, that sounds good. That sounds good. I need to control the budget. Need a lot of times they request what's that called? Publication fee. So I need to make sure that it's paid through some period of time that's within the funding time period.
Yeah. And then I did notice so on that on their website they had a thing where they make you search every co-author's name, and if the co-author already has an account, then you're forced to use their account. So you had an account, but then it was the email they sent it to was the email that's like not the VA email, but the one that's like Woodosis,
Yeah.
but they don't let me change it at all. So that was the only thing.
Use that for sure because that's our previous email address, and then they changed WashU's email address uniformly for everyone. Previously in the Department of Surgery is woodosis.edu, but then WashU decided to change to usto.edu, and I think right now they changed to washu.edu, I believe. So that makes our email address change, but I do receive everything that's sent to my Udosis account. So it's actually combined. So I will still get the email, but all of my previous account, journal account is registered under udosis.edu. So I'm very confused right now. So other people who are the corresponding author try to use my usto.edu, it doesn't work. And then I usually have two accounts within, let's say, JAMA or JAMA Network Open. It's just confusing. I always ask them to combine, merge the two accounts, but like you said, Udosis is definitely what I used before.
Gotcha. Okay, perfect. It'll send there, and then yeah, I mean, fingers crossed. I hope they at least send it to external review.
This one is a really good one, but I don't know why we got so many
Yeah,
rejections.
it's so much bad luck with it. And then even
Yeah,
like JAMA, so JAMA Internal Medicine and JAMA Network, they both like yeah, they kind of rejected it very quickly.
yeah. I mean, I'm surprised. I mean, this one is definitely an interesting one. I mean, comparable, if it's not better than the BMI trajectory one, I think this one is definitely comparable and of good of interest for sure, but I don't know why.
Yeah, yeah, but yeah, and then I think like Byron's busy, but we were talking about maybe like the next plan. I think a good next step is if we can just quickly start drafting the SGLT2 study.
Yeah.
So we can draft all the other things, and then once the new because I think we were gonna change we were gonna change something about the covariate, right? One of the covariates we were gonna change how we collect it. The anemia.
Oh,
I don't remember. Too many projects. I'm very confused now. So
Yeah, no worries. I think it was the anemia. It was how we capture anemia because of Dr. Sanfilippo's point that honestly it was a very good point. I totally forgot that this drug effect, but SGLT2 inhibitor will increase basically hemoglobin. It increases
oh,
hemoglobin. Yeah, I think usually it's about a 1 point, but she's saying it can go up to 2. That actually is very true. I honestly I totally forgot as we were doing the study, but yeah. So we were talking about categorizing like a way to categorize that um, before the final publication or the final manuscript.
May I think we can use something like the not non-constant hazard, like kind of like piecewise, what's that called? Time varying, not time varying, covariate. When we tested the proportional hazard assumption, right? Proportional hazard assumption, we kind of assume that they have a similar effect in different time points during the follow-up. But then if there is some cross, then we need to identify the time where they cross, right? And
Yeah.
and that we apply some sort of time varying analysis. Maybe we could do similar things for that variable. Let me think
Oh,
about it. So
mm,
that could be like the anemia, the biomarker for an anemia. And then we look at somewhere it crossed, or at somewhere it increase or decrease, I don't remember the mechanism, and then it make the myeloma become not myeloma, or it became myeloma faster than the other. I mean, I don't remember exactly, but we can look into that.
yeah, it's still time varying, but it's just only one changing point.
Yeah, exactly. But we need to look into the literature at what time point, usually at what time point it started to take an effect and then could
Right.
influence the diagnosis of myeloma.
Mm-hmm.
Then we use that time point to figure out what's going on.
Yeah, but I think so that captures any changes during the SGLT2 period. But then one other thought I had is because you know like the historic anemia. So like whatever the clinician sees as the anemia state before MGUS even um like and even during follow-up period, it does influence like the frequency of laboratory and other testing. And so one thought I had is if we wanted to have like a 1 year before MGUS diagnosis and track like what the maybe the median hemoglobin is and use that
Myeloma
as a
or
covariate.
MGUS
Or
diagnosis.
sorry, MGUS. I meant MGUS diagnosis.
And
Because it does influence like how often it would influence how often the clinician is going to follow the patient, depending on like the hemoglobin level.
well, Lawrence, is it possible that you can help summarize what everybody says in terms of the SGLT2 effect on myeloma diagnosis in the email? I think Marty also mentioned that SGLT2 could possibly increase or decrease creatinine. He
Yes, that
mentioned
is
that
true.
creatinine, and also Sanfilippo brought up the hemoglobin, right?
Yeah,
Yeah.
so
So
she brought up hemoglobin.
yeah, so if this can be in an email, so then we can kind of start to think about how we design our study to take those into account. That would be good.
Okay. So basically, regarding Dr. Sanfilippo's comment on the hemoglobin being affected, and then Dr. Schoen's
Yeah.
comment on the creatinine effect. So then how would all the co-authors suggest designing the like how we capture the covariables?
Yeah, I mean,
Okay.
I don't need their suggestion about how to
Uh,
capture covariables. I just need to understand the what's the effect of SGLT2 on the diagnosis, not because of the progression of MGUS to myeloma by itself. It's just the drug itself will increase or decrease whatever marker that kind of confuse people to and then confuse or maybe get the influence the timing of myeloma diagnosis. Does that make sense?
So what is the theorized effect of SGLT2 inhibitor? What would be the effect of the SGLT2 inhibitor with these specific covariates on progression?
Right. My
Okay.
with effect of the SGLT2 on the markers that could influence the diagnosis of myeloma. So the progression time will be confounded by these markers, and that's because of SGLT2 influencing these markers, not because SGLT2 influencing the progression time.
Okay.
Yeah.
Got it.
Okay,
So-
I need this biological mechanism so then I can start to develop the research methods to be able to tease out these confounding factors.
Yeah.
Yeah.
We need a kidney doctor in the group.
Yeah, we
Because
can.
the thing is, this is also a kidney medication. The
We have
challenge
kidney
is
doctors. I have been collaborating with my kidney doctors.
Oh, I think you should ask the kidney doctors also because so when I was in residency, like the kidney doctors really liked SGLT2 because they said that it improves kidney function. There were so many studies that they said it improves
It's
kidney function.
improving, not making it worse.
It can so in my mind, theoretically, it could like it could be unsafe to use in certain circumstance, and a lot of times if the patient loses a lot of fluids from this drug, then maybe they could have kidney injury. But I think a lot of the kidney doctors like will use it to protect the kidneys and to improve kidney function.
I see.
That's why it's like it's challenging because it depends on like if the patient is currently stable, they're fine and they have chronic kidney disease, this drug can improve their kidney function. But like if they're not feeling well and you start this drug, they can also have a lot of side effects.
I see. Well, I need that information so that
Yeah.
that can help me think through the study design.
Yeah.
Yeah, that will be great if you can summarize all of these emails so then we can start to think through how to get everything done by considering all of these different factors. Yeah, I was traveling, so I saw these emails and then I did not have time to put them together into one place. But I think it's a good time to do this right now so then we can redesign our study to get rid of those noises. Try to reduce
Yeah.
noises. Yes.
Yeah. Gotcha. Okay. So I think maybe it's best if I send the email in the same thread of that we were discussing for the ASH abstract. And then also, do you want it sent to all co-authors, like everyone that was on the original co-author email for the
It's
ASH
okay
abstract?
to just send to us at today's meeting so then we can start to think through and then when we have a cleaner study design, we send to all co-authors and see what they think.
So then just everyone in this group and then also Dr. Schoen, since he was here today.
Oh, yeah, for sure. Or, I mean, send to all co-authors is fine as well. That's fine. Yeah.
Okay. All right, will do.
Okay. Sounds very good. Okay, need to end this meeting. I have back-to-back meetings starting from 1 and I haven't gone to bathroom. Need to go now.
Okay. All right. Yeah.
Lawrence, can you stay
mhm.
for a little bit? I wanted to,
Okay.
or Sushi, if you still have 1 minute, Lawrence, do you remember last time we were discussing about updating the NLP algorithm on getting biclonal?
Oh yeah, that one
Yeah.
needs to be
Oh,
discussed
yeah.
too.
Yeah, I already
Okay,
did it
yeah.
before my trip. I sent you an follow-up email.
I'll let you continue to discuss. I
Yeah,
really
you can
go
go.
to the bathroom.
Yeah,
You okay
bye.
if I hop off too?
Yeah,
Yeah,
go
All
ahead.
right.
you are fine to hop off.
Bye.
All
See
right,
you
see
I
you
next
will
guys
week.
come
next
back.
week.
Bye.
All right,
Bye.
see ya. Bye.
See ya. So, Lawrence, I think I sent you a follow-up email on August 8th, with some comments and updates.
Wait, let me see if I can find it. Sorry.
Yeah, I can share screen if you can see my screen.
Oh, okay. I think I got it.
Yeah.
It's August 7, right?
Mm, well, it
I just
shows
have one
August
from
8th.
August 7. Oh, okay. Because it was I guess California time it was August 7th.
Oh,
Oh, that was
oh,
why. Yeah, because I
okay.
think for me it'll say August 7th. Yeah, okay.
Okay, I usually work
So
very late. Yeah, okay.
mm,
Yeah, just like, because thank you for sending those bullet points. I was able to know what exactly where to work on. So I think for the first point, I incorporated that, and then for the second point, about light chain MGUS. So the current algorithm, current NLP algorithm is purely based on the SPEP results. So I think if in the future we want to confirm light chain by combining SPEP at FLC ratio, we can do that, but that will be like not in this algorithm, if that makes sense.
I see. Like it would take some more development to bring it
Yeah.
in. Okay.
Yeah. Like it could be easy because we already have FLC ratio. It
Mm.
was just one more step.
Gotcha.
The third one is we should probably require at least 2 SPEP tests at least 3 months apart for confirming each protein for biclonal. I wonder if you meant because it's biclonal, so it could be like 2 separate SPEP reports.
I meant like it should show up on two, like basically. So what happens is sometimes if you get an SPEP, like if someone got a cold and then you check an SPEP later, you might see like several different proteins. But that's a normal process because when we catch a cold, we'll have a lot of antibodies, right? So like
Yeah.
right after an infection, people will often have like a lot of certain clones of antibodies that are very high. So it'll almost look like a biclonal or polyclonal result. And so I was thinking like maybe 2 sets of SPEP reports that corroborate the same 2 proteins. Like they have 2 reports that capture 2 proteins on them.
Oh, I see. Well, the current algorithm is on like treating those separately. Like on one SPEP report, we see if there are 2 proteins mentioned.
One SPEP report, 2 proteins mentioned.
Yeah,
the-
because
the- mm,
a lot of times, like when I was manually reviewing those reports, I saw it's like they will mention IgG kappa equals to a amount, and then IgG lambda equals to a amount.
yeah, exactly. Like I think if it like basically like if there's at least like during this patient's MGUS like period, right? If they have at least 2 SPEFs that show both proteins, because sometimes what happens is one protein might disappear and then come back a little bit later, like it goes up and down. And so like some of the SPEP reports might like it might be like this first SPEP shows both, then the next 2 don't, and then the next 2 only shows one of them, and then the third one or the fourth one shows both of them. So like if they have at least 2 that confirms it, then that's good. Because also sometimes like they get illnesses and then they get an SPEP check and it'll show like the protein. Like one might just be an accident. Like they just caught a cold and had that and it disappears.
Well, I see, but then that will be like redesign this algorithm because currently, like I said, it's like treating each SPEP result report separately. So only based on this report, we conclude if this patient has IgG kappa or is biclonal, and then the next one.
So like the
But
SPEP, like if one SPEP had two proteins, then the NLP
it's
will just say
biclonal.
there's this and that, and they're separate.
If one result shows two proteins, then NLP will say, okay, this is biclonal, and what are the two proteins are.
So
That's the current
it only
algorithm.
requires one.
Yeah, it doesn't. If the next one shows only one protein, it will say, oh, this is IgG kappa. Like that. And in the end, we because one patient, like you said, has multiple reports, right? And then it will calculate which one has the highest frequency. That's the current algorithm.
Yeah, I
Mhm.
see.
If most of the reports shows this patient has biclonal, then in the end, the patient level results, it will be biclonal.
So it requires like a majority of the
Mm.
SPEPs to show biclonal. I see.
Yeah, because one patient could have so many reports.
That's true.
Yeah.
What's the percentage? Like what's the frequency before it says it's biclonal? Do you remember?
Oh, I don't know. Let
It's
me
okay.
get back
Yeah.
back to you. Yeah.
Yeah, it's okay if not. Like I guess that's fine because that is
Yeah.
that I mean that's at least more sure. My only thing is just in case if it's like because I couldn't find anything in the literature that talks about like do they start with MGUS and then they become biclonal like so we don't know when the time frame is going to be. So if they already had an MGUS and had like 50 SPEP checked, and then the
Mm,
last 20 before myeloma diagnosis had a second protein, you know what I mean? Like so then
mm,
that's like a little challenging because it's like, okay, they they were biclonal, but this may not be categorized as biclonal.
mm.
That's my challenge. That's why like I felt like if we have at least like two SPEPs that show two different proteins, then that should be good enough to say, okay, this is likely biclonal.
I see. Do you think it will be like more assured, like we add a step to confirm biclonal? Like at least two reports shows. Well, I don't know. I think you are saying that we are missing something, right? We're missing some
We're
biclonal
gonna
cases.
lose, yeah, we'll lose a lot of
Okay.
biclonal because the
Okay.
current rule is very strict. Um,
Yeah. Oh, I see what you mean. Hmm. So you see 3 months apart, at least 3 months apart.
yeah, it's more just arbitrary, like oh no, it was because 3 months because that's kind of how long I would expect for if someone had like a natural development of an antibody, like it would
Mhm.
start to subside after 3 months or something.
I see.
Also,
Well,
3 months is more of like the soonest that someone will get followed for MGUS. It's like people typically won't get followed um, sooner than 3 months for MGUS.
I see. Okay. Maybe we can discuss this with Sushi to see what she thinks.
Yeah, I think this.
About it?
Oh, you're back.
Yeah.
Yes, biclonal. I was just going through the current algorithm. It's like this one patient could have like 100 SPEP results, right?
Oh, yeah.
SPEP reports, and the current algorithm is treating each report separately. So for within one report, we like the NLP algorithm will identify this as either biclonal or IgG kappa or IgG lambda, and then after all of those, going through all of those reports, we find the one that has the highest frequency, like majority of the report says that this patient has biclonal, then it will be biclonal. If
Okay.
a majority of the reports shows IgG kappa, then in the end, patient level result will show this patient has IgG lambda. But Lawrence was worried that we might lose a lot of biclonal patients because it could happen that one report, it only mentions IgG kappa, but the next report, it mentions another protein. This could also be biclonal. But our current algorithm won't capture this because it treated each report separately.
So you are saying the same the same report, they mention two different
Proteins. That's the current,
proteins.
yeah, that's the current algorithm. But we could miss some biclonal patients because it could be one report mentions only one protein, but the next report mentions another protein.
I thought you take the highest frequency among all of the reports.
Yeah, but
Are you saying that it's
Oh,
within
you're
the
right.
same report?
You're right, actually. We do capture like okay, if the first two proteins with the highest frequency and the same frequency, then that's biclonal.
Across all reports.
All reports.
Lawrence, is that missing anything? Or
Yeah, this could potentially solve the problem, I think.
so this is not how the current,
It is because okay,
but
my
why do we solve the problem if
initial
it's already?
theory. So my initial theory was to, based on just one single report, if two proteins were mentioned, then that should be counted as biclonal, right? And throughout all the reports, if like there are so many reports mentioning two proteins on the same report, then this is biclonal. But when I was coding it, my coding was calculating the frequency of the proteins being mentioned. And the first two, the two proteins that are mentioned most frequently and has the same frequency, then that's biclonal. I think it could capture the situation when this patient has one report mentioning only one protein, but the next one mentioning the other protein. What my algorithm actually treated it the same as two proteins mentioned in one report because both of them has the same frequency.
But what's the problem right now? Is it right or it's not right to do
I
this?
think it is right. Lawrence, did you get me? Like, why the current algorithm actually could capture the situation that we were talking about?
I guess so you're saying that like it will capture the frequency of both proteins separately, and then if the frequencies are similar, then it won't be captured as biclonal.
Yeah.
But I guess the challenge is if one protein came earlier than the other, then the frequency would be inherently different though.
Like very
So that
different.
the frequency could be different depending on how often the SPEP was checked before the second protein appeared. That's kind of what I was worried about is if we lose a lot of biclonal patients.
So what you are saying is, let's say protein A is more appear first and more frequent than protein B. But then protein B is like less frequent and but still appear.
Oh, I meant more just from the standpoint, even if you assume that they both are equally frequent, like if protein B came later, then like when you kind of calculate it over all the total SPEP, it's gonna be less frequent because it appeared later.
Mm.
Mm.
That's what I'm worried about is we'll lose a lot of biclonals because of that definition. So my original proposed definition is like if they have at least two SPEP showing two SPEP at least 3 months apart showing both proteins, then it could be classified as biclonal.
Then we will have a lot more biclonal, May. Would that be the case?
Yes. I
Because
guess
right now
so.
your algorithm is more more
Restrict.
more
Mm.
restrict than more stricter
Mm.
than
Mm.
what Lawrence mentioned.
Yeah, definitely.
Yeah.
Yeah. I'm trying to think. The other challenge is because biclonal is so rare that there's not like a consensus definition of like there's not like a consensus way to define it.
So let's try Lawrence's algorithm and see what's the difference. Would that
Okay.
need to take a lot of time to run?
No, that won't be it won't because the current NLP algorithm already has the capability of abstracting the proteins from each report. So we'll just tweak the way that we define,
Categorize.
categorize them.
Okay. Okay, then that's easy. We can maybe show the percentage. And so Lawrence may be able to see would that algorithm make sense or not making sense.
Yeah.
And
Yeah.
see the difference between the two.
Yeah.
Yeah, maybe we can when May has the results, we can write an email and then have the two results side by side, and we can describe you algorithm A versus algorithm B and the percentage after algorithm A, percentage after algorithm B, and then you can let us know whether that is reasonable or not.
Sounds good. Yeah, I think it would be helpful to see. Like, I think for our other studies, like just looking at MGUS, we shouldn't. I wouldn't recommend changing anything, but like at least for this study, it would be interesting to see the numbers.
Why are we? Can you remind me why are we interested in biclonal? I think you mentioned some idea, right?
Yeah, just because biclonal is also one of those areas where it's so rare. Like I think in the largest database, it was only like 400 or 500 patients with biclonal, and I guess it's technically called biclonal gammopathy. And so, like Dr. Johnny Karam was suggesting that it would be interesting to have like an exploratory analysis showing like progression events from biclonal.
I see. And also, what was our preliminary results for biclonal? What's the percentage or how many do we have in our data? Do you remember, May?
Let me see if I can find it too, because I remember we
Did we do something?
I think Qiyuan pulled that
Yeah, did it.
out.
yeah, Qingyuan was working on this. Yeah.
Yeah, Qiyuan, do you remember?
Let me see. I'm trying to dig through the emails because I think we have it somewhere. Yeah, I can't find it. I'm trying to see.
That's okay. I think we can do it anyway, without knowing what we had before, like what we plan to do. Wait, the first email was from February 4? And then you follow up with the email on August 5th.
Oh yeah, that's when we talked about updating the separate.
Yeah. But I did not see Qingyuan put together a number.
I think it did. I think it was added to the same result sheet with the IGM project.
Oh, okay.
Yeah, I think it's somewhere in that. So I'm scrolling through it right now just to
To
see.
find out the percentage or the number of biclonal Qingyuan.
Oh, okay, I found it. So we
Oh.
stopped the project because it said I was talking with Chinyurin and May, and May explained that the biclonals were captured by NLP if a patient had two different IG subtypes. Basically, like I think it was the way it was captured, we wouldn't have been able to report the different like subtypes by percentage. And so, because they would need it for the baseline characteristics, so I think that was like challenging I was saying that it would be challenging to report it without the distribution of the different IG subtypes. So we decided to hold off at that point. But then let me see if I can find the original data sheet.
But still, Qingyuan did the preliminary result as like how many biclonal patients in our cohort? No, not IgM, biclonal. Oh, you mean number is smaller than IgM number? Couple hundred.
Let's see if I can find it.
Okay, that's fine. I think we can use the proposed algorithms to look for biclonal.
Yeah, I'll provide the numbers soon. So Lawrence, I also saw because they are
Oh.
Mm.
Oh,
Mm.
sorry.
Did you find it?
Uh, the number is small.
Okay, I was going to ask Lawrence, I also saw triclonal and polyclonal. Do yeah, I so the current algorithm actually treat them all as biclonal. Yeah, I wonder, is it okay, or we should tease them out?
Mm, I think I need to tease them out.
Other.
There.
Yeah, they should be the other category.
Okay.
Is it possible to be like, not typo, like misrecording or what's that called? Yeah, a
They
mistake,
they said polyclonal.
polyclonal.
Uh-huh. And triclonal, I'm pretty sure is saying
Oh, in the text, it says
yeah,
that.
yeah.
What's the medical terminology for this? Multiclonal, and then categorize anything more than biclonal to that category.
If there's not, we can just categorize them as other.
Yeah. Okay.
Mm.
Lawrence, does that sound good?
Yeah, I think there's not like a good way to because I was mentioning to May earlier, the problem is this area biclonal because it's so like so rare. It's also the same problem where the categorization is challenging. Like there's not like a clear um when I read through all the studies that we have so far in biclonal, it's so minimal and there's not a clear way that the data is represented and categorized. But I do feel like if we just strictly say biclonal, we should restrict to only biclonal, like two, and that's it.
Okay, so biclonal and other.
Yeah. Oh, and then the other point is like I mentioned earlier to May, like the problem with sometimes like the more multiple gammopathies, like the more like triclonal and polyclonal, the problem is you run the risk where it's not a true gammopathy and it's more like because you know sometimes when people catch a cold, if you check an SPEP, right, like maybe I don't know, like 1 month after someone catches a cold, they'll have multiple, they'll instantly have a polyclonal gammopathy.
Hmm.
So
So,
that's actually a physiologic process. And so that's what I was worried about is, yeah, like the triclonal polyclonal may actually be like a normal immune response.
Okay, then that's easy. So if we see multiclonal, triclonal, we just pretend that it doesn't happen, right? Just skip this one and then see among all of the SPEP test results across all of the SPEP test results, what's the highest frequency of the,
Yeah,
yeah,
Oh, okay.
yeah.
yeah. Okay. But
I
also,
see.
here's the other thing. Another thing to point out is, so there, it has to be only during the MGUS period. It can't include SPEPs during the myeloma period.
Mm, yeah.
So it has to be strictly before progression because I think I mentioned to me like a few meetings ago that sometimes after an autologous stem cell transplant, so the first line autologous stem cell transplant, patients that have a good response will tend to develop a second MGUS. So they'll technically have a biclonal MGUS, but this isn't the same as what we're talking about here. They develop it and then just for whatever reason, but that's a different process.
How about using SPEP test results before, like 6 months before progression to whatever that we define, like our NLP defined progression, 6 months before that progression date?
Oh, I
Or
think
one
he
Yeah,
year?
that's probably fine too. Yeah.
MGUS. I th Oh, so currently I'm using ever, like the first SPEP test.
To all the way to after they develop myeloma?
Yeah, but we can change it to because we did not define a time period for
Okay,
this
let's
before
change to 1 year or 6 months before progression.
Yeah,
progression.
I think
If
6 months
there
before progression is a good one. Yeah, I think we should do that.
Mhm.
if there is ever a progression, if they did not progress, we'll use it all the way to the last SPEP
Yeah, I
test.
think that's good.
Mm,
Yeah.
Good. Okay.
okay.
Okay, that's such a long meeting.
Yeah. Oh, by the
This is
way,
good. Productive.
Yeah, it's good, very productive, yes.
yeah. I will because I have class for the fall semester,
Oh, yeah.
which is conflicting with probably because Ted is also is not here either. Probably need to send out an email
Yeah,
about
let's Lawrence, would it be okay for you to join like an hour earlier, like starting from
2 to
two to
3.
three?
2 to 3 is 12 p.m. I mean, it's probably fine because right now I haven't started work yet, so it's
Oh,
probably
okay,
okay.
let's
Yeah, I
change
think it
to
works.
2 to 3 for now. And
Okay, yeah.
then after you start working and see your schedule, what your schedule is like, we can modify.
It sounds good. And then I might miss a few meetings in the first half of September just because I'm traveling. But the other meetings I should be able to be there.
Okay, yeah,
Okay.
that sounds good.
Mhm.
Okay, if we need your input, because these like biclonal or the IgM progression to Woodenstrom, we will email. I mean, we can email communicate. We don't have to discuss at the meeting.
All right, sounds good.
Okay,
Okay.
thank you, everyone.
Thank
All
you.
right, see you
See you
guys.
next week.
Bye.
Bye.
See you next week. Bye.
Bye.